ഹായ് എവരി വൺ. പി എസ് സി എം ഒയിൽ ഒരു ഇമ്പോർട്ടൻറ്റ് ടോപ്പിക്കായിട്ടുള്ള ഡെങ്കു ആണ് നമ്മൾ ഡിസ്കസ് ചെയ്യാൻ പോകുന്നത്. ഡെങ്കു ഇറ്റ്സ് എ വൈറൽ ഇൻഫെക്ഷൻ ദാറ്റ്സ് കോസ്ഡ് ബൈ ദ ഡെങ്കു വൈറസ് ആൻഡ് ഇറ്റ് ഈസ് ട്രാൻസ്മിറ്റഡ് ത്രൂ ദ ബൈറ്റ് ഓഫ് ദി Aedes aegypti or Aedes albopictus. It has 4 serotypes. Once it get infected by a serotype, it will never again infected by the same serotype. The next time it will be affected by the other variant of the dengue. Then coming to the vector, Aedes aegypti and Aedes albopictus, it is a day biter and it will rest in the dark corner of the houses and it will breed in the artificial collection of the rainwater. Coming to the dengue, it can be dengue fever, dengue hemorrhagic fever or dengue shock syndrome. In dengue fever, there is fever with temperature greater than 104 degree Fahrenheit, retroorbital pain, headache, myalgia, bone pain, nausea, vomiting, rashes. In dengue hemorrhagic fever, there is 3 phases: febrile phase, critical phase and recovery phase. It comes with clinical features of fever, thrombocytopenia, which means platelet count will be less than 1 lakh. And hemorrhagic manifestations, gum bleeding, epistaxis, hematemesis, melena, and evidence of leaky capillaries like elevated hematocrit, pleural effusion, ascites. And WBC count will be also low. In dengue shock syndrome, there is features of dengue hemorrhagic fever plus features of shock. This is the same. Then based on the tourniquet test, we can classify dengue fever and dengue hemorrhagic fever. In dengue fever, there is greater than or equal to 10 petechiae per square inch of skin in cubital fossa. In dengue hemorrhagic fever, there is greater than or equal to 20 petechiae. Coming to the lab diagnosis, the main thing is serological test. First is the NS1 antigen. We can do NS1 antigen from the first day of the dengue fever. This Aegypti ELISA can detect only after 5th day. Hematocrit count will increase, platelet count and total leukocyte count will decrease. LFT, chest X-ray and USG. Then classification of the dengue based on this we can classify dengue is mild, moderate and severe. In mild dengue, there is no any warning signs. There is just fever only. There is no platelet count is normal. There is no evidence of any capillary leakage or there is no any complications. In patients with warning signs, in patients with moderate dengue, there is dengue with warning signs. These warning signs are persistent vomiting, abdominal pain, lethargy, restlessness, bleeding manifestations, syncope, giddiness, clinical fluid accumulations like ascites, pleural effusion, lethargy, restlessness, enlarged liver. In patients with severe dengue, there will be shock, bleeding manifestations or organ involvements like there will be acidosis or dyselectrolemia. Coming to the management, this mild dengue can be managed on an OPD basis, while other 2 dengues like severe and moderate dengue, they are managed in a IP setting. Okay. Coming to the mild dengue, we are doing a symptomatic management. We are giving ORS for dehydration. For fever, we are giving paracetamol and colspongine. Then aspirin, ibuprofen and corticosteroids, they are contraindicated as there is risk of bleeding. We can use insect repellents and also we can eliminate the breeding place by various techniques. Then we should watch for bleedings or signs of plasma leakage or warning signs of dengue. In patients with moderate dengue with warning signs, we are starting the treatment with the isotonic crystalloid solution at a 7 to 10 ml per kg for 1 hour. These crystalloid solutions are ringer lactate or normal saline. If there is improvement, in every cases if there is improvement, we will gradually reduce the crystalloid solution. If there is no improvement, we will look for the HCT. If the HCT count is greater than 45%, then we will give IV crystalloid 10 ml per kg again for 1 hour. Then we look for improvement. If there is improvement, we will gradually reduce. If there is no improvement or if refractory hypotension, in that cases we will manage this severe dengue as a decompensated shock. If in every cases, if the HCT is less than 45%, then we will do blood transfusion. Okay. So in the same way, we are managing this decompensated shock and compensated shock. In compensated shock, here the BP is greater, systolic BP is greater than 90 mmHg and there is high HCT. In decompensated shock, the BP is less than 90 mmHg. Okay. Then when we are giving platelet, we are transfusing platelet only if there is bleeding. Then prophylactic platelet transfusion can be considered if the count is less than 10,000 without any bleed, or those who may need emergency surgery. Okay. Then when to discharge patient? If there is absence of fever for at least 24 hours without the use of the antipyretic drugs, and there is return of appetite, visible clinical improvement, good urine output, minimum of 2 to 3 days after recovery from shock, no respiratory distress from pleural effusion or ascites, and platelet count is greater than 50,000. In this case, we can discharge the patients. Now we can do a question of dengue. This is a PYQ. So the first option is, there is progressive increase in hematocrit with a rapid decrease in platelet count is a warning sign. So this is a correct option. Next option is, prophylactic platelet transfusion may be considered for count not less than 2 lakh, this is less than 20,000 without bleed. This is wrong option. Prophylactic platelet transfusion may be considered for count less than 10,000. It is not less than 20,000. It is less than 10,000. Okay, so this is a wrong option. And the next option is, pregnancy, obesity and peptic ulcer disease, they are high risk factors for severe dengue. This is also correct option. Blood transfusion should be given to patient with falling hematocrit with unexplained hypotension. So this is also correct. So the answer is option B. Thank you.